So my talk is on epilepsy surgery. It's a little different than what was written. That's SEEG and laser ablation. We are going to talk about that. But we're just going to talk about a lot of the newer technologies and techniques we have available. So my talk is called Lasers and Robots and Stimulators, oh my. So no disclosures. I put this in here to remind me. I'm going to show some pictures of brains and some of the surgeries and things. So I'll let you know that I'm doing that beforehand in case anyone's queasy or uncomfortable with that. So I'm going to start by talking about the importance of the history of epilepsy surgery. A lot of this that we do now is based on what we learned probably about 80 years ago, and then we'll talk a little bit about the benefits of that. Then we're going to talk about the implantation techniques. We're going to go over the two major classifications of epilepsy surgery that we do, and then talk a little bit about the difficult to treat epilepsies. And then in the end, we'll do some case illustrations. So around 80 years ago, there was a very tough question that people had, because what happened was that patients would come in and they'd have a lesion of some sort in their brain. It could be a stroke, it could be a tumor, it could be some sort of a abnormality, and they would have seizures. And the prevailing thought at that time was that if I remove the lesion, that the seizures should stop. But what they found was that they could remove the lesion entirely, but the patient would continue to have seizures. And so it wasn't until this man here in the middle at Wilder Graves Penfield. So it wasn't until around the 1930s, when he was operating out of Montreal Neurological Institute, that he did some very interesting experiments and really helped us understand epilepsy better. So what they did was they took patients who had a lesion, and they would do a surgery where it was an awake surgery. They'd take the bone off, they'd take the covering of the brain off, and they had an electrical stimulator, and they would stimulate the lesion itself. And while the patient was awake, they'd stimulate them, and they could not get a seizure to occur. Then what they would do is they would stimulate around the lesion, and they'd find that they could find an area around the lesion in which they stimulated it, and the patient would have a seizure. And what they found was that unless you removed both, the lesion plus that area, that was the only way to actually achieve seizure freedom. Since that time, in the last 80 years, we've had many papers and studies looking at the benefits of epilepsy surgery. We know now that if you fail 2 to 3 medications for epilepsy, that you're a candidate for surgery, and that you should be evaluated for that. We know that the risks of surgery are very low compared to the benefits that we can potentially get from that. And in terms of medication, you say, well, maybe they're going to come up with new medications. And this study came out at the end of last year. And what they said was that over the last 30 years, despite all the new epilepsy medicines we have, the overall outcomes in people who have newly diagnosed epilepsy has not changed or improved. So not only do we have a lot more information than they did back in 80 years ago, but we also have new tests. So we don't have to do these awake surgeries and stimulate the brain as they used to do before. Now we have non-invasive tests such as PET scans, MEG studies, MRI, SPECT studies. And with all of these tests, what this allows us to do is have a better idea in a non-invasive way at where the seizures are potentially coming from. With that, we also have a lot more information about some of the patients who have very difficult to treat epilepsy. And so the way I define that is that they may have failed epilepsy surgery in the past. They may have multiple areas, multifocal epilepsy. They may have epilepsy coming from parts of the brain that we can't resect. So the language area, the motor area, parts of the brain that would be unsafe for us. Or if we removed it, they would have some sort of a deficit afterwards. So now we'll talk a little bit about the surgical implantation, some of the types of surgeries we do. So I tell people in general, in epilepsy surgery, there's two broad classifications of epilepsy. There's diagnostic procedures, and what that means is that we do a procedure to get more information or learn something more about where the seizures come from, and then we have therapeutic surgeries. Sometimes we can go directly to a therapeutic surgery if we have enough information from the non-invasive tests. If, on the other hand, the non-invasive tests point to multiple parts of the brain, then we have to go and do additional testing with these diagnostic procedures. So I'm going to show some pictures of surgery, just again to warn you all. There's two basic categories of diagnostic procedures: subdural grids, which you see on the left, and then SEEG, which you see on the right. And To start with talking about SEEG, so essentially what that is that it's minimally invasive. We have pinhole openings in the skin, and we're able to implant these electrodes into the deeper parts of the brain. The benefit of that is that we can sample multiple lobes and multiple parts of the brain, and sometimes we can actually sample both sides of the brain, depending what we're looking for. Before we even talk about that kind of surgery, all the patients we do surgery on or offer surgery to, we talk about them in our epilepsy management conference. So that includes neurosurgeons, all the epileptologists, neuroradiologists, as well as neuropsych. Essentially everyone who takes care of the patient and what they do is they bring their own set of eyes and their own experiences to it. So when we come up with a plan, everything is tailored to that patient. This is what a pre-implantation hypothesis looks like. So if we wanted to target a certain part of the brain, we would, I would draw out where I think the seizures are coming from, and then we would implant it, based on that. We have a robot that helps us with the surgery. We were the first center on the West Coast and the 11th center in the country to have this robot. And one of the benefits of the robot, I do the entire surgery, but the robot helps me with my accuracy and precision so that we can implant these electrodes exactly how we want them to. This is what it looks like when we plan out, how we're going to implant the electrodes. So the next step is that we bring the robot in, and it actually goes, the robot is, the benefit of it is that it calculates all the trajectories and the implantation techniques so that we don't have to do that, with, calculations, and that prevents a lot of the human error that's involved with that. Then the next thing is that after we make an incision, we use the drill to actually get through the bone and actually get access to the brain. Then this is a small stylet we use. We place it into the deeper parts of the brain and actually get to see, we create a tract through which then we can implant these electrodes. Now, what you see there is the electrodes are very small. They're about 3 millimeters, 0.3 millimeters. And the benefit to that is that, again, it's a percutaneous, minimally invasive procedure that allows us to really have a good idea as to where the seizures are coming from. Again, sorry to show you these pictures. The reason I usually don't do that, and every time I give these talks, people ask me if they could see, what it looks like, what we do. So this time I thought I would include them. So this is the other type of surgery we do, subdural grids. So what this one entails is this is a larger surgery. This is actually where we implant grids onto the brain itself. And so what you see here is this is the incision. This is that's what the brain looks like when we have it exposed. And these are the electrodes that we then put on top. So at the end of all that, you may say, well, are subdural grids better than SEEG? Is SEEG better than subdural grids? Are they equal? Do we not have an answer to that question? And what I'd say is that in the end, the important thing to know is that it's really tailored to the patient. So we don't do surgery in a one size fits all. Every case that we do, we as a group sit down and think about what's the best thing we can do for that patient to best find where the seizures come from, and then based on that, what would be the best option. So we have some guidelines that help us. So if we think the seizures are coming from somewhere near the motor area or somewhere near the language areas, we'll usually go with the subdural grid. If we think that it's maybe a larger network, or maybe it's coming from both sides, we'll do SEEG. So that's kind of going through the diagnostic procedures. Now we'll talk a little bit about some therapeutic surgery options. So in some cases, if all the non-invasive tests point to one part of the brain, we don't necessarily have to go ahead and do that diagnostic procedure. We can go ahead directly to some sort of treatment. These are some of the treatments that we do. So on the top left, that's a temporal lobectomy. That's what that surgery looks like. On the right, that's a hemispherectomy. So that's removal of half of the brain. Now you may say, well, how does someone live after that? And in fact, the benefit of this is that you have to remember we're taking out abnormal brain. This is not normal tissue that we're removing. And so when we do this surgery, the most common thing is that when they wake up, they look just like they went to sleep. So there's really no difference because a lot of that is abnormal tissue. The normal side of the brain is the other side, and that's already taken up a lot of that function from beforehand. These are some of our lesser invasive techniques. What you see on the left, that's the NeuroPace device. The middle device is DBS, which is the most recently approved treatment. And then on the right you see is laser ablation. We're talking about all three of those. So I'm just going to stop for a second and talk about difficult to treat epilepsy.
How do you support the brain
I'm sorry?
How do you support the rest of the brain once you've removed that much?
Support the rest, how do you mean? Like,
Well, everyone says that, like in hockey injuries, they say about, the brain
shakes in there.
Around.
Right.
If you've removed that much, that brain can move that much more.
It's a great question. So the question is about, if you remove that much brain, what happens to the other normal side of the brain? So it's very interesting. Talk about a historical perspective. So when they used to do the surgery 60, 80 years ago, they didn't know what the answer was to that question. And what they used to do was they would take, and this is true, but they would take sterile ping pong balls and they'd fill that part of the brain with that. And the reason is that because they had no idea, they said, I don't know what's going to happen here. What I tell you that they do now, the truth is that we do it this way. The reason I would do it this way is that that fluid, that spinal fluid, cerebrospinal fluid, that actually acts like a cushion. So what happens is that whole area fills with fluid, and it acts just as well as if, and so, people go back to normal things. We do this surgery mainly in kids. We do it in adults too, but, kids go back to normal. You'd be surprised. To the level that they can, do normal things after that. So it's an interesting thing. Any other questions about that before we go on?
Just a follow-up on that one.
Yeah.
What's the recovery time on, say, for the brain to fill up with the fluid?
So the brain creates fluid at 150 cc's per day. So the actual amount of time for that to fill up is about a day or two. What happens more commonly is that the brain just has to, acclimate to now filling that area up and everything else. But from the surgery standpoint, that's about that. In terms of the recovery for the patient, I tell people about 4 to 6 weeks, but in reality, usually within a week or two, they're doing fairly well. So that it's not, everyone's different, but in general, in the week or two is about on average. Going back to difficult to treat epilepsy, one of the things I really, I feel strongly about is that there are patients out there that have had epilepsy surgery and who have failed. And unfortunately, some of those people will go back to their surgeon or go to another epilepsy center and say, is there anything else? And a lot of times they'll say, you've had the gold standard surgery, you had subdural grid, you had SEEG, there's nothing else left. And what I say, that's really the group that I feel that most strongly about, that there are people who we can still help. And so a lot of the things we're going to talk about now are some of the newer techniques and devices that we have that actually allow us to help people who have very difficult to treat epilepsy, meaning that they've failed surgery, they've failed multiple medications, to that extent. So here's the picture again. So what I'm showing here is that potentially you could have multiple areas where seizures come from, or you could have seizures coming from your language area or motor area, parts of the brain that if we remove it can actually cause you to have problems. The other thing you can have is seizures coming from both sides of the brain. So if unfortunately we can't remove both sides. That's the brain needs to have one of each of the lobes. And so in those patients, again, we have new options available. So NeuroPace is probably the most exciting of those. We've had that for about 5 years. And what it does is it acts similar to a defibrillator in the heart. And so what that means is that it listens, if we know where the seizures are coming from and we can't remove that area, it listens for seizures and it'll constantly be scanning for those. When it sees a seizure is about to start, it sends an electrical stimulation to that area and is able to abort or shorten the seizure, or over time it hasn't any benefits. In general, though, I always show this picture because what it is, NeuroPace is very different than every other treatment we have. In general, a lot of the other treatments, the seizure-free rate at the beginning after surgery is the best, and over time there is some fall-off. So we see that some people have seizures 10 years after surgery, 20 years after surgery. We don't really understand why that is. Some think that it's maybe because, if you stop taking your medication, maybe a new part of the brain, starts having seizures. Maybe it's that people's brains are wired differently, so maybe a new area of seizures, pops up. But NeuroPace is one of the only things that we have in which the actual seizure reduction goes up over time. So you see here that at the implant, at the very beginning on the left side of the screen, it's probably about a 30% response rate. So that means of 100 people that you put in, about 30 of those people would have about a 50% reduction in their seizures. But what's really exciting, this is actually a little older. This was 6 years of data, and that goes to about 50%. When you look at the newest data, about 8 years actually after surgery, after implantation, we see that about 70 or 80% of people have a 50% reduction in their seizures. And I have patients who have almost a complete remission of their seizures, and I have other patients who have significant reduction. So we see a huge group. Now, some people don't have immediate relief, and that's one of the things that again I show this picture for, because it's not necessarily that is expected. One of the things that's different about NeuroPace is that one of the things that the neurologist has to do is make adjustments to the device. Because if you imagine, what's happening is that the device has to see a seizure and then send a shock to stop that seizure from progressing. It may be that the brain doesn't tolerate, the seizure may continue unless you do it at a certain time or at a certain threshold, or all sorts of adjustments have to be made. But as you can see, over time, that improvement does occur, and that's why we go from 30% up to 50% in 5 years, and then up to 70 or 80% in the 7 to 8 year mark. This is deep brain stimulation. This is what our newest technique or technology available. This was actually only FDA approved in May of this year, and it's based on a study that was done a few years ago, but this is very exciting as well. So in patients who we know that they have seizures coming from one side of the brain, but we're not able to exactly localize where the seizures come from. One thing we can do is deep brain stimulation, and what that is we implant a small fiber, and then we connect a battery that sits in the chest, and it acts. And what it does is it just sends a electrical stimulation at a constant rate. It's not as smart as the other system in that it's not listening for seizures and sending shocks at certain times. It's actually just constantly sending a certain rate of stimulation, and for whatever reason, we see that there is some reduction in seizures with those patients. So. In the original studies, they looked at when they turned the device on, about 40% of people had a significant reduction in their seizures. And when they turned it off, only 15% had a reduction. And then at 7 years, we saw that 70% of people in the entire group had a reduction in their seizures. So this is the newest device that we have available. Medtronic is the company that makes this device. And they only picked 21 centers to be considered centers of excellence. And what that means is that if you want deep brain stimulation and you want to have that done at an academic center, there's only 21 centers in the country that currently have the ability to do that. And thankfully UCI was listed as one of those. And so we actually are going to be starting in the next few months implanting people for deep brain stimulation. And then the last one, of course, is vagus nerve stimulation. That's probably the one most people know about the most. The benefit to vagus nerve stimulation is that it works with focal epilepsy, it works with generalized epilepsy. In general, I think of it as if there's no other intracranial option available, this becomes your next best option for treatment. In general, it's about 50% of people have a 50% reduction in their seizures. More likely, it's about a third of people have a good reduction, a third of people have a small reduction, and a third have no change. This is kind of another option that we have available. It involves 2 incisions, an incision on the neck and then an incision in the chest. And basically the battery lasts about 4 to 6 years. So going back to neurostimulation, so RNS, really it's the best options for people who have unresectable epilepsy. They have bilateral epilepsy that we can't remove both sides, or as an alternative to resection. So if you have a patient, or if there's a patient who can't have an area removed for many different reasons, then RNS is an excellent option. In terms of deep brain stimulation, it's also similar in that it's for people who have difficult to localize epilepsy or focal epilepsy that we can't remove. And then vagus nerve stimulation is kind of the catch-all for all the patients if they have difficult to localize epilepsy, and that can also be generalized or focal epilepsy. I'll talk a little bit about robotic surgery. We were, as I said before, the first center on the West Coast about 2.5 years ago. Really, this is how it works. You can see here. This is the device. This is our robot. So we've already picked and planned all the trajectories beforehand. And what the device does here is that it holds the drill. It helps me then perform my surgery in the safest way possible. We've written a lot of papers on it. Really, we've done some of the first in man type procedures for this. We did the first deep brain stimulation with the robot We've used it for laser surgery. We've used it for all sorts of different things. SEEG is probably the most common one. We'll talk about laser ablation now. This is also in the last few years we've had this available to us. One of the benefits of this is that you can actually do what used to be a major surgery that involved a large incision, large resection, a lot of brain retraction, and we've turned it into a much smaller surgery and people go home the next day. Probably the most useful use of the laser is for hypothalamic hamartoma. And what I'd like to tell people is that this is a patient who had a hypothalamic hamartoma. This is a 26-year-old of ours who came in with that. You can see here that little lesion there, it's hard to even see, is that's the area where he's having seizures from. And the way I describe it to people is that I say, imagine if you take a basketball and you cut it in half, and then you float a Tic Tac right in the middle of that basketball. And then I give you a straw and I say, I want you to pass the straw through the basketball and hit the Tic Tac with one pass. And you can't be, anywhere else other than at the Tic Tac. That's essentially what this surgery is like. And one of the things that's very nice about the robot and all the other things that we have that help us is that we're able to actually do this kind of surgery. So this is the surgery we did. So you can see that small circle with the white around it. That's where the actual ablation occurred. So we passed the laser cannula. We were, exactly where we wanted to be, and then we were able to just with a very small amount of heat burn that area. And the benefit to the patient was that he went home on day one and has been seizure-free for actually over 2 years now. Now we talked about seizures coming from areas in the temporal lobe. What happens if seizures come from an area that we can resect, but then also that extends into an area we can't resect? So something like what I showed you here. Well, this was another patient of ours, 33-year-old woman who had 15 years of seizures. And what you see here is that right where that yellow circle is, she'd had a trauma in the past, and there was a small blood clot, and they did a small surgery to treat that. And since that time, she'd continued to have seizures. And what we see is that on this MEG study, which is the study below, all the seizures, the spikes, look like they were coming from around that area. So because that area is very close to her language area, what we chose to do is something like a subdural grid, like I mentioned before. That circle again is where you see where that cyst was, and then that red rectangle is actually where her language area was. And we were able to actually map that by stimulating each of those electrodes, and we could see exactly where her language area was. Now in her, this was a very challenging case because she had seizures coming from the area where that cyst was, but also from the language area. And unfortunately, we couldn't remove of course we can't remove the language area. So what we did was a hybrid surgery. We removed that cystic area plus the area around where the cyst was, and then we placed an RNS over the part of the brain that her language and seizures were coming from. And this is what her RNS looks like. So when she has seizures, you can see that there's, the seizure starts to develop, and then it fires, and that actually stops the seizure, right in its tracks. And the way that she describes it, and the way that she describes her seizures now is that she has problems with speaking, and then all of a sudden she feels something, and then she goes back to normal. And so that's some of our neurostimulation devices. That's kind of just a broad overview of what we can offer in epilepsy surgery. Does anybody have any questions about any of the things we talked about?
Just wondering if somebody's already had surgery and they have like a titanium plate and screws in their head, is there even the possibility of having something implanted post that, or would the metal plate and screws
No, in fact, we actually use the same metal plates and screws to fix the RNS in. So it's more, it would be if, for people who have continuous seizures, those kind of things.
So they wouldn't counteract it anyway?
No.
So your robotic arm gives you the trajectory for the laser?
No. I'm sorry if it wasn't clear. So the robot, what it does is the video I showed earlier where we were implanting the electrodes, what the robot does is that, if I say I want this target and this entry point inside the brain, what the robot can do is it can take me directly to that area. So I have that correct trajectory. I know exactly how long that distance is. I get a lot of information from that. With that robot, then what I'm able to do is then I can do that surgery. You saw where I was drilling and putting the electrodes in and all that stuff. So what it does is it gives me that accuracy. Before that, we used to have different types of frames that we would put on the head, and that would allow us to put these electrodes in, but the accuracy was not as good. You also had to do a lot of calculations to make sure that you were correct in terms of.
So it's still manual.
It's the whole surgery is manual. I always tell you I do that surgery. This just helps me be.
Tells you where.
No, I mean I tell the robot where, but what it does is it gives me that accuracy. So if I say I want to be here, it's going to take me right there. That's really all that it is. So I joke it's kind of a dumb robot. It's not like some of the other robots that are out there. Any questions about any more?
I was just wondering, you were saying, the lasers through the brain until it reaches that point that you're operating on. I'm just wondering, in the pathway that it has to go to, does it sometimes damage a section that's going to reach the area that needs to be surgically?
Yeah, so the question is about putting the laser in and whether it can cause damage to the brain. So the laser fiber is, again, less than about 1 millimeter. So it's very, very small. We do special testing. We get a special MRI before we do any of the surgeries. And the MRI, what it does is it looks at all the blood vessels. And so I know where all the blood vessels are in the brain, and I can create trajectories that allow me to avoid any of those blood vessels. So not only the lasers, that's a good question for the laser, but the same procedure I talked about, the SEEG procedure, the same thing. We want to make sure that we don't injure any of those blood vessels. If we injure a major blood vessel in the brain, it can become a major complication. And so we're very careful about that. And so we do a lot of special MRIs and the robot and things like that. All are there to help me with this. So again, to answer your question about the robot, it also adds this level of safety because I can know with very good precision exactly where I'm putting that electrode.
And actually, I'm surprised too that you're essentially, in extreme layman's terms, frying at a lot of the types of surgery the part that's damaged. But I thought in some cases, like scarred brain tissue can actually be the cause of seizures. So I'm kind of surprised that this,
Well, so the question is about scar tissue and surgery, and then if you burn an area of the brain, does that not cause so there's a difference between scar tissue that's created by a trauma or a tumor or anything else versus this trauma that we create when we do surgery. So obviously, when we do surgery, that we create some small area of trauma or burn or injury to that area, but with the it's a different goal, and it's also more controlled. So if you get a head injury, traumatic brain injury, and you get seizures after that, that's very different than if we do a controlled surgery where we very carefully, take a small area and treat that.
and the other kind of scarred brain tissue, is that called like sclerosis?
Sclerosis is one, in general, when we talk about scarred brain tissue, we say it's called encephalomalacia. So encephalo means brain, and then malacia means abnormal or damaged brain.
And what is new, the hippocampus?
So hippocampal sclerosis, mesial temporal sclerosis or hippocampal sclerosis is when the hippocampus is small. It's not necessarily trauma related, it's more just abnormal hippocampus. Any other questions? No? All right, well,
All right, I have a question.
sure.
What did you do with the piece of skull you took off now?
Yeah, so it's a small piece, and then we just take it. We send it to a
I told him
pathologist.
you should ask for it, and he was creeped out when he got the surgery, so he's like, no, and now he's like, dang, I should have asked for that.
Well, people ask. It's funny that people ask for when I do resection. I take out a piece of brain. People ask for that. They ask for all sorts of things. We can't give it to them because it has to go through the pathologist and things like that. Sometimes we can take a picture of it. That's usually the best that we're allowed to do for.
I even denied that at the time.
Yeah, I think I'd asked you or you asked me, and it was,
I was too freaked out.
Yeah,
about it.
right.
Well, too freaked out. Looking at those pictures you showed, I was just like.
Well, and that's also why I give you that. It's funny because it's so funny. I've given this talk a lot of times, and every time it used to be, this is the first time I actually showed some pictures, but before that I never did. And people would always say, can you show us a picture of the brain or show us this and that? So I said, okay, I'll show it once.
Yeah,
You know,
probably my head with that RNS.
Considering what it looked like that we just saw, we were like, whoa. He didn't really have a lot of pain.
Yeah, that's actually one of the
Pretty minimal.
That's one of the benefits of the surgery, especially the SEEG over the other surgery I showed you, in that because it's percutaneous, minimally invasive, it's not that much in terms of pain. It's really, and even the other surgery is not that bad overall. I mean, it's a little bit more of a recovery, but again, that SEEG is really, it's actually, again, it's not one that's better than the other. it's really for what the problem is. But yeah, it is one of the benefits of that is it's a lot less invasive surgery.
Yeah, Rose is pretty gentle, guys.
Yeah.
She's pretty cute too.
Yeah, right?
First time I get to see her. Aw.
In some cases, do they keep what they remove for research and conserve it?
Yeah, research. We do a lot of research on the parts we remove, and also there's lots of different testing we do to it. Yeah, absolutely.